I'm Jeremiah Stamler, the Executive Director of the Chicago Health Research Foundation and Associate Professor, Department of Medicine, Northwestern University Medical School. I'm convinced that a mass of evidence exists demonstrating that diet is one of the key factors responsible for the current epidemic of severe premature atherosclerotic disease in the United States population and accounting for the very high incidence of heart attacks in the middle decades of life in our country.
I'm Dr. Mark D. Altschule of Boston, Massachusetts. I'm Assistant Professor of Medicine at the Harvard Medical School, lecturer in medicine at Yale University. I'm convinced that diet can now have a primary role in the pathogenesis of atherosclerosis.
I'm Dr. David Miller from the Atlanta Field Investigations Unit of the Heart Disease and Stroke Control Program, U.S. Public Health Service at the National Communicable Disease Center in Atlanta. I'm here to serve as moderator for these discussions of this critically important subject.
Welcome to the exploration of concepts and controversies in modern medicine, one of a series of programs dedicated to examining the uncertain, candidly recognizing that much of today's teaching is necessarily based upon opinion and that the opinions of eminent physicians in a given field vary widely. The National Medical Audiovisual Center believes that openly airing such opposing views is a basic responsibility of medical communications. Dr. David Miller, National Communicable Disease Center, will act as moderator of this presentation.
First, Dr. Jeremiah Stamler will present some of the evidence from his work and from that of others, suggesting strongly that diet and atherosclerotic diseases are causally related and that appropriate changes in diet offer the possibility of prevention of these diseases. Dr. Stamler?
Let me, Dr. Miller, first point out the scope of the problem confronting us. 600,000 coronary deaths a year in the United States, 165,000 of them in persons under 65 years of age, 3 men for every woman, with about twice as many non-fatal crippling events. This is one of the highest rates in the world, not only compared to the less developed countries of the world, but also compared to the developed countries of Europe, the British Commonwealth, and so forth. We rank very near the top. I think only the Finns beat us out in this regard, and I guess we can say we're like Avis. We're second, but we're trying harder. Now, study after study of these international differences, both analyses of United Nations data, World Health Organization data, the very important international autopsy study done by our colleagues at the Louisiana State University Medical School, together with the very important field studies of Dr. Keyes and his group in 12 different populations of Europe, plus the Japanese, all show a very close correlation among the pattern of the diet, particularly the saturated fat intake, the dietary cholesterol intake, the serum lipids of the populations under study, and the incidence and mortality rates, as well as the prevalence rates of coronary heart disease, that is, of fatal and non-fatal atherosclerosis of the major coronary vessels. Now, this is one of the most important pieces of evidence. I would underline the fact that the distribution of serum cholesterol in the population, the mean levels, the rates of hypercholesterolemia differ markedly among these countries, and along with that, the coronary rates differ, and only diet can explain these differences. For example, countries like the Greek islands of Corfu, of Crete, which have been studied intensely, southern Italy, Dalmatia, Japan, have much lower mean serum cholesterol and triglyceride and beta-lipoprotein levels than we do. Their coronary rates are much lower in middle age. This correlates directly with their saturated fat and cholesterol intakes. It's importantly related also to their intake of total calories, but there's a great deal of evidence to implicate the fat component of the diet as the most important one. This is not to say that this is the only dietary factor, nor is it to say that diet is the only factor, but it certainly is a key and important one. Cigarette smoking also enters into the picture, and physical inactivity, as well as high blood pressure and other risk factors may as well. I want to stress that diet is involved in at least 4 ways, not just in relation to serum lipids. Diet is, of course, related to overweight. Diet and exercise or lack of exercise are both related to overweight. Overweight as well as high serum lipids are coronary risk factors. In addition, diet is related through overweight to risk of high blood pressure. Fat people get more high blood pressure than people who are lean throughout life, and diet is related to the risk of diabetes, again, at least because fat people get more diabetes than lean people. And hyperlipidemia, overweight, hypertension, and hyperglycemia or diabetes are all major coronary risk factors. I therefore find it very difficult to believe that diet is unrelated. We also have the massive evidence of experimental atherosclerosis, namely that the sine qua non for the reproduction of severe atherosclerosis, and our problem is not just atherosclerosis in general. All of us have some of that. None of us at this moment are sick from it. The thing that makes for morbidity and mortality is severe atherosclerosis, and the only way one can produce severe atherosclerosis in species in the laboratory, avian, mammalian, herbivorous, omnivorous, carnivorous, including monkeys, primates, is by feeding diets high in saturated fats, high in total fats, high in cholesterol, and raising the blood lipid levels, particularly the blood cholesterol levels. And unless man is radically different from all other species and is a departure from the basic laws of evolution, I cannot but regard this evidence as extremely important. Finally, we know from a vast series of epidemiologic and clinical investigative studies that by altering the kinds of diets we're eating at the present time, we can shift the distribution of serum lipids to the left, or in plain, simpler English, we can lower the lipids, not just of hyperlipidemic people, but of whole populations. This was shown in the National Diet Heart Study in a double-blind, controlled open population study in an institution, and at the present time, at least 4 major long-term field trials in New York, in Chicago, in Los Angeles, and Helsinki indicate that such nutritional changes are associated with a decreased rate of coronary disease in middle-aged individuals. In brief summary, then, all of these pieces of information strongly indicate to me that diet is one of the key factors in the contemporary epidemic, and that to end this epidemic, we must do something about the diet as well as other major risk factors such as cigarette smoking and hypertension.
Thank you, Dr. Stamler. Next, Dr. Mark Altschule will present some of his views emphasizing the inadequacies of the dietary data and casting doubt upon the hypothesis that diet is causally related to atherosclerotic disease. Dr. Altschule.
Well, first, let me say that there are certain aspects of the dietary problem that we all agree upon. If a man's too fat, we try to reduce him. If he has diabetes, we treat it with diet. If he has hypertension, we may treat it with diet. But what I'd like to emphasize is that these are only peripheral and, in many cases, very subsidiary factors. The main etiologic factor cannot be diet, and there's very little evidence to support the view that there is any connection. For example, the vast amount of animal work that has been done with the feeding of cholesterol is imperfect in several respects. In order to get any significant amount of atherosclerosis in some of these animal species, one must elevate the blood cholesterol level to about between 2,000 and 4,000 milligrams. Now, it's extremely rare for any man, sick or well, to have a cholesterol level over 1,000, and most of us run around 250 or 300. So that applying the data obtained with levels of 2, 3, or 4,000 to what obtains in man with a level where 300 is considered high, I don't think is very good logic. Moreover, there's some question about whether the cholesterol that's introduced into the diet of these animals in order to produce atherosclerosis is quite the same as the cholesterol we eat, because it has to be separated, processed, and purified. And there's one school of thought that believes that certain impurities develop in the handling of that cholesterol. There is, in fact, are toxic products that damage blood vessels and induce the disease, and it's not the cholesterol per se. But at any rate, I would say that the animal experiments are most unconvincing, and particularly with respect to the fact that certain species will have one strain in which a very high cholesterol diet does seem to produce atherosclerosis, but the same species with another strain can take exactly the same diet and have no atherosclerosis at all. With respect to the statistical studies, the epidemiologic studies in man, they too, of course, are imperfect. The authors of the report of the Helsinki study and of the Los Angeles study, in their own reports, said that their groups were not matched. The one from Los Angeles, in particular, referred to the fact that one of their groups smoked more than the other, and they hadn't taken that into account before starting it. They said they didn't think it made any difference. I don't know on what basis. These statistical studies that would be required to establish in man that the kind of diet that Dr. Stamler refers to is the primary cause of atherosclerosis, is so huge that the likelihood of their ever being carried out is remote. There have been papers on that subject by epidemiologists, and I won't go into them in any detail because they've already been covered. The matter of getting the blood cholesterol down is interesting, but I'm not sure how important it is, because we don't really know where the cholesterol goes after it leaves the blood. For example, if you just add a few parts per million of cadmium to the drinking water of a rat, you lower the blood cholesterol by about 40 or 50%. But the cholesterol all goes into the blood vessels, and these rats have much more atherosclerosis than the rat without that cadmium in the drinking water. So that when reports say that the cholesterol is diminished by 10, 15, or 20%, unless such a report can say where the cholesterol goes, I don't think I'd be willing to accept it as evidence for anything except an interesting laboratory finding, and laboratory findings, unless they're directly related to clinical phenomena, can be extremely misleading. As far as I know, there's only one phenomenon in which a lowering of the blood cholesterol has been related to an increase in cholesterol breakdown, and that is with exercise. If you give radioactively tagged cholesterol to an exercising animal or a man, you can show that carbon dioxide is coming off, and therefore the cholesterol is being broken down. Now, other ways of lowering or cholesterol levels in the blood don't carry that implication with it at all. I think the emphasis should not necessarily be, in fact, shouldn't at all be on lowering a cholesterol. The emphasis should be on influencing the cardiac status. And when a patient is put on a diet with a change in fat content and so on, and his blood cholesterol goes down 15%, but he loses 40 pounds in weight, if his cardiac status improves, I'd be more inclined to relate it to the fact that he's lost some weight, rather than to the fact that his blood level has changed. I don't believe that levels of changes of 15 or 20% in the level really amount to very much. First place, the blood cholesterol level is a very variable thing, and if you take your blood from a patient who's not likely to enjoy being stuck, the blood cholesterol will go up and you get a false high reading. The current practice of advancing upon the patient with a large syringe, a large needle, a toothy smile, and a comment, "This won't hurt a bit," is not likely to change the blood cholesterol very much, except in the upward direction. So I would say that whatever evidence I've read does not support the view that diet is of primary importance in the genesis of atherosclerosis.
Thank you, Dr. Altschule. You've raised some important questions from animal experimental work, implying that much of this work is with overloaded animals, from epidemiologic work, pointing out the imperfections of some of it. I shan't summarize any more, but turn now to Dr. Stamler for his comment on some of Dr. Altschule's points.
Well, each of them could be dealt with at some length. I'd like for a moment for us to discuss the experimental aspects. I think that it is true that many of the studies have dealt with massive additions of cholesterol and fat to the diet, but this is not the exclusive situation. As a matter of fact, old Anichkov himself, the man who began the experimental work, was one of the first to feed relatively small quantities of cholesterol in natural form, let me add, not as crystalline chemical material, but as eggs or milk or animal tissue. And he did so over long periods of time with only modest elevations, Dr. Altschule, of blood cholesterol into the 200, 300, and 400 range, not into the couple thousand range, without the production of massive organ cholesterosis, but with the production of significant atherosclerosis. Dr. Katz, Dr. Pick, and I did the same thing with chickens in the laboratory at Michael Reese. What we did was to give less of the cholesterol and fat in the diet over a longer period of time, thereby mimicking in the composition of the diet very closely the kind of diet that's being eaten at the present time in the United States. Dr. Bruce Taylor has done the same thing with monkeys, and I guess one of the neatest experiments in this regard is by Dr. Robert Whistler at the University of Chicago, who's fed two different diets to primates. First, the usual American diet, no synthetic cholesterol added, the chow, the grub, such as we eat it every day, day in and day out, most of us in the United States today, versus the so-called prudent diet of the New York Anti-Coronary Club, the kind of diet that we've been recommending through the Heart Association, through our coronary prevention program. In those primates, only a moderate elevation of cholesterol ensued in the first group, eating the usual American diet. Again, no organ cholesterosis, but again, definite atherosclerosis developed. So I think there's no doubt from primate studies, from rabbit studies, from chicken studies, that you can reproduce the lesions of human atherosclerosis in a variety of species by dietary means of a longer duration, but sort of corresponding to what goes on over our lifespan, because it does take 3, 4, 5 decades from the time we begin eating the American diet, so that our blood cholesterol rises from the cord blood level of 80 up to about 180 or 190 by age 20, and up to about 230 by age 30. This is the American pattern. We used to say that this was physiological. This was the normal human response until we began to go out and look at other populations. In the Japanese, it goes from cord blood 80 to 140 or 150 by middle age. In southern Italy to 160 or 170, where the total life expectancy is better than ours. The total death rate in middle age is much less than ours. The coronary death rate, much, much less than ours. So I think this argument about cholesterosis and massive feeding is only part of the truth on this question.
I agree also with Dr. Stamler about the invalidity of the studies in which such high amounts of cholesterol were given that cholesterol was deposited in the blood vessels and a state of cholesterosis developed. What I was referring to, rather, was the fact that cholesterol, even in smaller amounts, produces anemia in experimental animals. And in view of the fact that a considerable amount of evidence has been accumulated that shows that the endothelium of the arteries is a barrier to cholesterol infiltration until damaged, and the fact that hypoxia is one factor that will damage the lining, I think cholesterol may be toxic without producing this massive deposit that we both deplore in these experiments. And I might add that the hypoxic factor of damage to the endothelium probably explains the propensity of heavy smokers to develop atherosclerosis, because they carry about a 10% saturation of carbon monoxide in their blood all the time, which is enough to damage the vessels. I'd like to pick up one other statement that Dr. Stamler made. He said that the experimental animal developed a kind of atherosclerosis that was much like the human. However, in the conference held in New York about a year ago at the New York Academy of Sciences, one of the experimenters with primates made a specific statement that animal atherosclerosis had never reproduced what we saw in man. That can be taken both ways. It might be species differences, or it might be a truly significant difference between the experimental and the actual. I'd like to enlarge a bit on the matter of the endothelium as a barrier. The hypothesis was developed chiefly in Scandinavia, but has appeared in the American literature in a paper by Silversmith and Newman. And I think the point is well made that a host of factors may damage endothelium and allow cholesterol, which would come through in very small amount, to accumulate. And that the cholesterol is not the cause of the atherosclerosis, it's this lesion of the endothelium itself. And that, along those lines, we have the experiments by Patek on the production of arterial lesions by a humoral factor not involving cholesterol at all. And of course, when it comes to a consideration of what the possible primary factor in atherogenesis is, I think we can have recourse only to the work of Texan, which studied the hemodynamic factors and brought out the importance of them. I should like also to point out that although cholesterol levels may be predictive in Framingham, Mass., they're not at all predictive in Hawaii. And so when we come to factors that are predictive in one place and not in another, I think we have to look behind them for their true significance.
I wonder if we might at this point agree perhaps to disagree on some of the animal experimental and pathologic work and get into the epidemiologic work, and especially the subject of what might be or what might not be recommended to patients or to the American public in the way of dietary change, in the hope that it might forestall some of this morbidity and mortality.
Well, I agree.
Dr. Stamler, would you?
Well, I'd like to start in that discussion with a set of facts. We have just looked at both our own study in the People's Gas Company and in the pooled data of 6 studies, Framingham, Albany, Los Angeles civil servants, the Minneapolis businessmen, the Western Electric study in Chicago, and our gas company study. And we're impressed by the fact that there are, unfortunately, a minority of Americans with serum cholesterol levels under 250, the average for this cut being about 210, with normal blood pressure and without cigarette smoking. And these people fare remarkably differently from the great mass of Americans with high lipid levels, with or without one or another of these factors. In fact, if one does 5, 7, and 10-year life tables on these people, the coronary death rate, the sudden death rate, is about 1/6 that of the population that has the traits I've mentioned, and total mortality is about a half. Now, I think we can make one simple recommendation, and as a matter of fact, I find this to be universally supported, and I hope Dr. Altschule supports it, and that is certainly we should go after those high-risk people who are extremely coronary prone in our population, and aside from controlling their hypertension and their overweight and their hyperglycemia and their cigarette smoking, do something also to shift their lipids over to the low-risk group so that we can buy them some protection against the very high risk they have at the present time. From all our experience, a reduction in saturated fat intake, in cholesterol intake, if you will, the Mediterraneanization, I'm stumbling over that hard word, of the American diet, which incidentally permits very pleasant eating and which can lower the cholesterol 15 or 20% very easily for high lipid people. This kind of approach should certainly be fruitful for high-risk people.
May I stop now and ask Dr. Altschule his reaction to that? What, in view of the imperfections of the data thus far, what do you think should be recommended for now and the future?
Well, I think that people should not be pigs, and they should eat reasonably, and if a man's fat, he should be thinned down. But beyond that, I don't see that there's any need to limit the kind or specific kind of food. We all know that there are large variations, even within families, of the selection of food. And yet, the whole family may have coronary disease. In fact, they may all die of it before they're very old. The matter of an excess of unsaturated fat bothers me a little because it can become toxic. And whether or not unsaturated fat can give rise to intimal lesions is still a matter of discussion. But in large amounts, it quite definitely is toxic in animals. Another thing that I think is somewhat important is the fact that eating has more than caloric significance. It has a social and an emotional significance. And I have dined with some friends of mine who are on this low cholesterol, high unsaturated fatty acid kick, and I must say I'll never go back to dinner at those homes again.
Let me attempt to summarize first by emphasizing some of the points on which we agree, that morbidity and mortality from atherosclerotic diseases presents a tremendous health problem in this country and in other industrialized countries, that central to the core of understanding these diseases and of their cause lies disturbed lipid metabolism, and that there are multiple other causes which are complexly interrelated and very difficult to separate and enumerate any one. We have not agreed as to the role played by diet. I think Dr. Stamler believes that it is of primary importance, and I believe you believe that it is of secondary importance. We have agreed, I believe, that something needs to be done more effectively than we now are doing about these diseases, and I hope that at some future time, we may be able to come to this sort of agreement.
We thank Dr. Jeremiah Stamler, Dr. Mark Altschule, and Dr. David Miller for their interesting analysis of a critical problem in patient care. In subsequent programs, we shall continue to record equally significant concepts and controversies in modern medicine. The opinions expressed on this program do not necessarily constitute endorsement by the Department of Health, Education, and Welfare, the Public Health Service, or its constituents.